Hi, welcome back to The Educated Nurse. We're going to do another quick video today on the differences between STEMI, which is ST elevation MI or myocardial infarction, and an NSTEMI, non-ST elevation myocardial infarction or MI. We're going to look at those two differences and just kind of compare and contrast symptoms and treatments. If you're new to us, you can follow us on Facebook and Instagram. We also have a shop on Etsy and Shopify where you can find study guides and templates, practice NCLEX questions, and a bunch of merch too. So let's dive into this new EKG quick video. All right, I just wanted to jump on and first start off with what is normal sinus rhythm. This always is a great place to start, and we actually have a video on the 10 points to normal sinus rhythm. But just as a reminder, for normal sinus rhythm, there are 10 criteria that you have to meet. The rate should be between 60 and 100. The rhythm and regularity, it should be a regular rhythm. So all the beats should march out in a uniform fashion. The P wave, there should be a P wave before every QRS. The PR interval, the P wave, and the QRS complex should be within normal ranges for their measurements. And the ST segment should be at baseline. There should be no elevation and there should be no ischemia. You will see a T wave. You probably won't see a U wave unless the patient has low potassium. And there should be no early beats and no late beats. All right, let's start with ST elevation MI or a STEMI. You can see in the EKG there's some abnormalities. It's not normal sinus rhythm. The rate is normal. The patient might be tachycardic, but in this instance, if we were actually to look at this EKG, the rate is actually normal. Now, the rhythm and regularity is abnormal, okay? And it's going to be abnormal or irregular when we look at some of the other criteria moving down the line here. In this particular EKG, there is a P wave and there is one before every QRS, so that's okay. If we were to measure the PR interval, we would find that the PR interval is normal. There is a QRS complex. Now, in some instances, when you look at this EKG, this is a 12-lead EKG view. So it's looking at 12 different areas of the heart. And in some of the views, the QRS complex is normal. Okay, you can see that in leads 2 down at the bottom. Some of these leads, you're going to see that it's abnormal. Okay, so we're going to get into that in a minute. The ST segment, some of them is normal, some of them is elevated. For example, when you look at lead 1 up at the top left-hand corner, you can see that that is not at baseline. That ST segment is not at baseline. The ST segment actually curves and goes upwards. You can see in lead 3 that the ST segment is actually depressed. And then you can see in the AVL segment, again, that ST segment, instead of that QRS coming back down to baseline, the QRS only comes down a little bit and then it curves back up. That is ST elevation. And this patient is probably having an MI. I know that this EKG shows that they're having an MI, but they are definitely having a heart attack. So if you see ST elevation where that ST segment is not at baseline and it is elevated, that needs to be addressed and brought to the physician's attention ASAP. In these particular EKG, there are no U waves, there are no early beats, and there are no late beats. Down at the bottom of this slide, this is just nice to know information, okay? You don't need to memorize this by any means, but I just kind of wanted to show you, and there's going to be another video on how to apply a 12-lead EKG and a 5-lead EKG. But for now, just so you have an idea, this 12-lead EKG, we're seeing some abnormalities in lead 1, 3, and AVL. So if you look down at the bottom, you can kind of see that lead 1 and AVL means that the patient is having a lateral ischemia. So when you're looking at the different areas of the heart, the lateral side of the heart is where this particular patient is having a heart attack. And again, you don't need to know it, you don't need to memorize it, it's just nice to know information. What causes STMI or a STEMI? There's a lot of causes. Your main causes are going to be cardiac related, whether it's a valve problem, heart failure, coronary artery disease is a big one, etc. A bunch of different options with heart stuff, especially if you've got a congenital issue. That's going to be your main cause. Clots or ischemia are another cause. Ischemia is just decreased blood flow to that area of the heart, most often usually related to a clot, can be for other reasons. Drugs, especially your stimulants like cocaine, methamphetamine, especially if you see that in a young person. Chest trauma could also cause a heart attack, especially if there was blunt force to the chest. Symptoms for a STEMI, the patient could be asymptomatic. I actually just had a patient with a STEMI not too long ago in the ER, and they presented with just mild shortness of breath and some upper respiratory symptoms. She actually came in thinking that she had COVID and wanted to be tested for that. No signs of chest pain or anything else. When we got her labs back, it was like, whoa, Batman, you are having a heart attack. All right, so they can be asymptomatic. Most patients are going to have symptoms. They're going to complain of that chest pain right in the center of the chest. It might be sharp. It might feel like pressure. I've definitely had patients say, like, it feels like there's an elephant sitting on my chest. That pain may radiate. Some patients will complain that the pain goes up into their neck or into their jaw or off into their shoulder. Some patients will complain that the pain goes from their chest straight into the back or like in between their shoulder blades. Everybody's kind of different. You might also have patients that are kind of non-specific symptoms, like you might see this in women, although it's not classic, but you might see like nausea type symptoms, or they feel just nauseous, or they're not feeling well, or they've got GERD like symptoms or acid reflux type symptoms. They could have shortness of breath. They could be dizzy or lightheaded or have neuro changes. Again, the first stop on the oxygen train is the brain. So they could be having some neuro changes if their head's not getting enough oxygen, the brain's not getting oxygen. They could have a fever, and it's not because of an infection, it's due to an inflammatory response. And then again, that nausea, heartburn, epigastric pain right in the stomach. I would say if you have any concerns about whether or not this person might have a cardiac related cause for their chest pain, or if something's just not adding up, or they passed out, or they're having just weird cardiac symptoms, or your spidey sense will kind of go off with this. If you're unsure, just do an EKG, right? It's quick and easy. And really, if a patient comes in to your place of business or the ER or clinic or whatever, and they're complaining of this chest pain, you really should do an EKG within 5 minutes of that patient presentation. How do we diagnose the STEMI? EKG, right? And then a troponin level. A troponin is a cardiac biomarker that gets elevated. It gets released into the bloodstream when the heart is under stress. It releases this enzyme. It's highly specific to the cardiac muscle. The bummer with the troponin is that, say my symptoms started 30 minutes ago, that troponin level is not going to be elevated right away. It's going to take a few hours. So it's not uncommon that if a patient comes in and they're like, oh man, I have this crushing chest pain, it just started like 30 minutes ago, that we repeat that troponin every few hours to see if there's a rise in that. The best thing to get your diagnostics in is to do that EKG. That's going to give you a snapshot in time right now, and it's going to show you if that patient's having a heart attack. So EKG and troponin level for a STEMI. And then patient presentation. If something's off and they're just not feeling right and you're concerned about this, they're probably going to be in the ER for a little while and like observe, so you can repeat some of these diagnostic tests. So what do you do if your patient's having a heart attack or a STEMI? Always, always, always support their ABCs. Airway, breathing, circulation, and support that if you can. Start an IV. This is where I would say 2 IVs are better than 1. Start 2 IVs. And part of that is they have the potential to be really unstable. And 2, if you're going to have to give multiple medications, it's not a bad idea to have 2 separate lines because some meds can't mix. Okay. The ultimate goal if your patient's having a heart attack is to get them to the cath lab within 90 minutes or less. Okay. Where I work, we're a rural hospital, so getting them to the cities where the cath lab is could certainly take 60, 90 minutes. And so you have to really kind of think about what other treatments you're going to provide. Other things you're going to do And this is really going to be patient specific and sometimes even cardiology specific as to what they want to give. The old acronym used to be MONA, which was morphine, oxygen, nitro, and aspirin. That's not certainly the current standards and the case for treatment anymore. It certainly can be done, but it's not like everybody gets the same treatment. So it's going to be patient and cardiology or ER doc specific as to what they're going to do. But for the most part, you're going to give aspirin. Usually it's 324 or 4 of the 81 milligram baby aspirins. Most of them are chewable. All right, so aspirin, nitroglycerin. Most of the time you're going to give sublingual and they just put it under their tongue. You can give them 1 nitro every 5 minutes, up to 3 doses. You could also consider doing a nitroglycerin infusion, but that would typically come from the cardiologist. It's not something that most ERs are going to start and do right away. Because we don't want to make any more clots and we want to keep their blood nice and thin, they're probably going to get a heparin bolus. So it's really important that you get the patient's weight so you can accurately dose your heparin. If they do a bolus, most of the time they're going to go on to a heparin infusion and they stay on that actually through their cath lab procedure. Lately, though, I've seen that some cardiologists just want the infusion and they don't want the bolus. So again, patient specific. If you're a far distance away, and I've only actually seen this done twice in my career, and it's been when I've been working at the rural hospital, because I used to work in a university hospital where we had a cath lab. So if a patient came in, they would go straight to the cath lab. There was no delay in care. Being that I work in a rural hospital now, I definitely have had a delay of care sometimes. And so we have actually given thrombolytics like tenecteplase as a clot buster in anticipation of the fact that we were going to have a delay in treatment and a delay of care, and we weren't going to get that patient to the cath lab in less than 90 minutes. So we gave tenecteplase to try and break up that clot. Tenecteplase, if you're going to give that, you definitely need 2 IVs, and you have to watch your patient for signs of bleeding because it is a blood thinner and a clot buster, and it could certainly cause some abnormal side effects. You have to be really careful with your patient. You have to monitor them. Pretty much it's one-to-one care if you're going to be giving that. Pain management. If this patient's coming in and they're having really bad chest pain, everybody deserves good pain management. And morphine actually is a really great pain medication for a couple of reasons. One, it's going to help with pain. It's an opioid. But 2, it's also a coronary vasodilator. So giving them morphine, it does multiple things. It's going to help treat their pain, and it's going to open up the coronary vessels to help with blood flow. So morphine's a great choice for pain medication. Cardiac medications, it used to be that everybody gets a beta blocker. We would have this clot box in our Pyxis medication stand, and beta blockers, like everybody would get a beta blocker, and it's just not current practice anymore. So again, you kind of have to just see what the doc or the cardiologist wants on that, but it's not 100% standard practice across the board anymore. They'd probably go home on some sort of rate control medication afterwards, but it's not standard in the emergent phase to give that. And then when you think about ongoing treatment after an MI, they're probably going to have to get on some cholesterol medication and then some sort of rate control medication. They might have to be on a blood thinner for a while. It really depends on, what the cause of their heart attack is and what the cardiologist wants them to be on going home. So that's kind of a STEMI in a nutshell. Let's look at NSTEMI next. All right, next up is NSTEMI, or non-ST elevation MI. So when we looked at the STEMI, we would notice that ST segment was elevated. In an NSTEMI, you're not going to see that elevation. And actually, the patient could have a pretty normal EKG, right? And so you're not going to be like, well, you're having all this severe chest pain, it's 10 out of 10, but your EKG looks normal. That doesn't necessarily mean that they're not having a heart attack. They could be having an NSTEMI. So you might not see ST elevation. You might see some ST depression, or you might see some T-wave inversion, and that again could be a sign of ischemia, but you're not going to see that characteristic like huge ST segment, the ones that look like a tombstone like you would see in a STEMI. You're not going to see that in an NSTEMI. So the rate and regularity, it's going to be irregular because we have an abnormality with our normal 10 points here, right? And that ST segment is probably going to be depressed, and you're going to have some T-wave inversion. So that's what's going to be different when you're looking at those 10 criteria to normal sinus rhythm. So you can kind of see that in the EKG here. You're going to see that depression or inversion versus that high ST segment elevation in your STEMI. In your NSTEMI, ST depression, ischemia, or they could have a normal EKG. All right, let's look at NSTEMI. So NSTEMI, what are the causes? They're the same as your STEMI. Mainly your cardiac issues, your heart failure, coronary artery disease, ischemia or blood clots. It could be your stimulant drugs again, and it could be that chest trauma. Pretty much the same as a STEMI. Most of them are going to be cardiac reasons. Symptoms, same as STEMI. They could be asymptomatic, chest pain, may or may not radiate, shortness of breath, neuro changes, nausea, fever, cool, clammy skin. Again, same as STEMI. How do we diagnose an NSTEMI? This is different than your STEMI, okay? So in an NSTEMI, like we talked about with EKG findings, you want to get that EKG done within 5 minutes, but with an NSTEMI, unless you're really good at picking up on those little nuances or those little abnormalities like the ST depression or the ischemia or the T wave inversion, their EKG, even though they're having this really bad chest pain, their EKG could be normal, especially if you don't pick up on those little nuances. You might need to do serial EKGs where you're repeating your EKG to see if there's any changes. The patient presentation is huge. If I'm having 10 out of 10 crushing chest pain, but my EKG is normal, I would still be really highly suspicious of a cardiac event. The other big thing, the gold standard for diagnosing an NSTEMI is the troponin level. And again, with the STEMI, like I talked about, the troponin level might not be in the bloodstream right away, especially if the patient's symptoms just started. So you might have to do serial labs here. So this could be the patient that comes in, my symptoms started 30 minutes ago, I'm having 10 out of 10 chest pain, my EKG looks normal, my troponin is pretty normal. This would be the patient that you would want to repeat your EKGs on and repeat your troponin in a few hours. If it's elevated after a few hours, they've got an NSTEMI. Or if their EKG is normal, they have these terrible symptoms and their troponin is elevated, they're having an NSTEMI. All right. Now, their troponin could be elevated for other reasons, but for the most part, if they come in with a cardiac presentation, that would be something to worry about. Okay. What do you do for an NSTEMI? The treatment is going to be pretty much the same. However, you're probably not going to rush them to the cath lab right away. Okay. It's not like where in the STEMI you want to get them there within 90 minutes. They definitely need cath lab intervention, but in my experience, it is not always as quick as with the STEMI. With the NSTEMI, again, you're going to support the ABCs, get 2 lines going. Aspirin, may or may not do nitroglycerin with these patients, just especially depending on where in the heart they're having this NSTEMI. Heparin, and again, a bolus versus an infusion is pretty common. I've seen patients that have had an NSTEMI and all we've done for them is heparin, and then we get them to the cath lab and they might go later that day or the next day. But the heparin is kind of the key here, just to make sure that, you know, everything stays really slick and smooth and, you know, your blood's not clotting and all that. They would want to consider an antiplatelet medication along with the heparin. And that's kind of been, for me in my practice anyways, that's kind of been a new thing I would say in the last couple of years, is that they're adding on that antiplatelet medication as well. Things like Berlinta is one of the ones that we do quite a lot actually. Pain medication, cardiac meds, again, beta blocker, maybe, maybe not. And then thinking about ongoing treatment, these patients will probably get, you know, their heart kind of roto-rooted and they may get stents. So it could be very similar to a STEMI. But that initial management is going to go pretty much on the cardiologist, and if they can get them into the cath lab and, you know, how long it's going to be. Most patients, like I said, for an NSTEMI are going to get aspirin, heparin, and then some sort of antiplatelet, and then get them to the cath lab when it's appropriate, when it's available. All right, thanks for watching this quick video on STEMI versus NSTEMI. If you want to know more about EKG interpretation or you're struggling with this a little bit, I offer a study guide. It's over 50 pages long. It can be found in our Shopify or Etsy store. You can like and subscribe to watch more videos. I'm going to do a whole bunch on this EKG series. So on atrial ventricle dysrhythmias, normal versus abnormal blocks, whole bunch of stuff. So stay tuned with us on that. And then as always, follow us on Facebook and Instagram. And if you need to reach out or have any questions, don't hesitate. We'll catch you on the next video. Thanks for watching.